In this lecture, I'm going to talk about HIV and AIDS, going to talk about various kinds of treatments that are available, the antiretroviral drugs, talk about risk factors, ways to slow down the epidemic, patterns, and so on. I think you're going to learn a few things that you hadn't heard before. You'll have to let me know. But don't worry about taking notes on percentages and dates and all kinds of numbers. Listen more to what I'm saying and pick up patterns and some of the more important aspects to this. And look at the study guide to get a clue for the kinds of things that you really ought to be focusing on for this lecture. Since the beginning of the epidemic, 76 million people have been infected with the HIV virus, and about 33 million people have died of HIV/AIDS. Globally, 38 million people were living with HIV at the end of 2019. An estimated 0.7% of adults aged 15 to 49 years worldwide are living with HIV, although the burden of the epidemic continues to vary considerably between countries and regions. The WHO African region remains the most severely affected, with nearly 1 in every 25 adults, or nearly 4%, are living with HIV and accounting for more than 2/3 of the people living with HIV worldwide. HIV and AIDS remain a persistent problem for the United States and countries around the world. While great progress has been made in preventing and treating HIV, there's still much to do. An estimated 1.2 million people in the United States had HIV at the end of 2018, the most recent year for which this information is available. For those people, about 14%, or 1 in 7, did not know their HIV infection status. In 2018, nearly 38,000 people received an HIV diagnosis in the United States in dependent areas. The annual number of new diagnoses decreased 7% from 2014 to 2018. In 2018, gay, bisexual, and other men who have sex with men accounted for 69% of all new HIV diagnoses in the United States and 6 dependent areas. In the same year, heterosexuals made up 24% of all HIV diagnoses. If we look at HIV diagnoses by race and ethnicity, we see that blacks and African Americans are most affected by HIV. In 2018, adult and adolescent blacks/African Americans accounted for 42% of all new HIV diagnoses. Additionally, Hispanics/Latinos are also strongly affected. They accounted for 27% of all new diagnoses. There are also variations by age. Young people aged 13 to 24 are especially affected by HIV. In 2018, young people accounted for 21% of all new HIV diagnoses. All young people are not equally at risk, however. Young gay and bisexual men accounted for 83% of all new HIV diagnoses in people aged 13 to 24 in 2018. This includes young gay and bisexual men who inject drugs, and young African American gay and bisexual men who are even more severely affected. The dramatic decline in annual HIV infections has stopped, and new infections have stabilized in recent years, according to a CDC report just recently published. The report provides the most recent data on HIV trends in America from 2010 to 2016. It shows that after about 5 years of substantial declines, the number of HIV infections began to level off in 2013 at about 39,000 infections per year. Substantially reducing the number of new infections has proved more challenging, however. Efforts to prevent HIV transmission from mother to child have been a success, but HIV-related aid to developing countries has leveled off since 2010 and does not look set to rise. Also to blame might be an increase in unprotected sex in places that now have a reduced perception of HIV risk, the report says. In other words, when HIV first came on the scene, and I'll show you some time points in the next slide, in the 1980s, an HIV diagnosis was considered a death sentence. Now that there are some really effective treatments, which we'll talk about towards the end of this lecture, people are now looking at it as a treatable, manageable disease, and they're not taking the kinds of behavioral steps that they could to protect themselves. Today, HIV, human immunodeficiency virus, remains one of the largest pandemics in the world. HIV is the same virus that can lead to AIDS. Researchers found the earliest case of HIV in a blood sample of a man from the Democratic Republic of Congo. It said that the most common form of the virus spread from chimpanzees to humans sometime before 1931. Most likely during bushmeat trading. While hunting chimpanzees, hunters would have come in contact with animal blood. Before the 1980s, researchers estimate that about 100,000 to 300,000 people were infected with HIV. The earliest case in North America was confirmed in 1968 in Robert Rayford, a 16-year-old who never left the Midwest and never received a blood transfusion. This suggests that HIV and AIDS may have been present in the United States before 1966. But before AIDS was identified, the disease presented with other immunodeficiency conditions like pneumocystis pneumonia and Kaposi sarcoma. A year after scientists identified AIDS, they discovered the cause, HIV. Originally, people believed that only certain people were at risk for HIV. The media named them the 4-H Club, that is, hemophiliacs who received contaminated blood transfusions, homosexual men who reported higher incidences of the disease, heroin users, so people who were using drugs by injection, and Haitians or people of Haitian origin. Many cases of AIDS were reported in Haiti in the 1980s. But then researchers studied how the disease spread. By 1984, they found that females could get HIV through sex. There were more than 3,000 diagnosed cases of AIDS in the United States, and of those cases, almost 1,300 people died. The National Cancer Institute identified HIV as the cause of AIDS. The number of cases continued to grow as the CDC refined their case definition and scientists learned more about the virus. By 1995, complications from AIDS was the leading cause of death for adults in the 24 to 44-year age range. About 50,000 Americans died of AIDS-related causes. African Americans made up 49% of AIDS-related deaths. But death rates began to decline after multi-drug therapy became widely available. The number of deaths has since dropped from almost 40,000 in 1996 to about 15,000 in 2000. Now, if you're interested in kind of the history behind the identification of the agent that causes AIDS and even the recognition of AIDS as a separate disease, I would recommend that you check out And the Band Played On. It's available in a book. It's kind of daunting. It's a really thick book, but it's a good read. Or you can, if you prefer video forms, HBO has a really good movie based on the book, and it's very accurate. And I've put on the slide information about both of these. It's a really interesting story because there was a lot of infighting amongst scientists, politicians. There was all kinds of prejudice associated with it. I really recommend that you check out one of these two sources. This slide shows you the changes in life expectancy in some of the countries that have been ravaged by AIDS in sub-Saharan Africa. Based on data from the World Bank, HIV and AIDS affects economic growth by reducing the availability of human capital. Without proper nutrition, health care, and medicine that is available in developed countries, large numbers of people are falling victim to AIDS. They will not only be unable to work, but will also require significant medical care. The forecast is that this will likely cause a collapse of economies and societies in countries with a significant AIDS population. In some heavily infected areas, the epidemic has left behind many orphans cared for by elderly grandparents. The increased mortality in this region will result in a smaller skilled population and labor force. The smaller labor force will be predominantly young people with reduced knowledge and work experience, leading to reduced productivity. An increase in workers' time off to look after sick family members or for sick leave will also lower productivity. If we focus on persons 25 to 44 years old, it emphasizes the importance of HIV infection among causes of death. Compared with rates among other age groups, the rate of death due to HIV infection is relatively high in this age group, but rates of death due to other causes are relatively low. HIV infection was the leading cause of death amongst persons 25 to 44 years old in 1994 and 1995. In 1995, HIV infection caused about 32,000 deaths, or 20% of all deaths in this age group. The rank of HIV infection fell to 5th place from 1997 through 2000, to 6th place from 2001 to 2009, then fell to 9th place in 2014, causing about 2,000 deaths, or 2% of all deaths in this age group. And some of these differences have to do with education, people modifying their behavior, taking steps to reduce the risk, but also treatments, and we'll talk about that later on in this lecture. Among women 25 to 44 years old, HIV infection was the third leading cause of death in 1995, when HIV caused more than 5,000 deaths, or 11% of all deaths in this group. Thereafter, the rate of death due to HIV infection dropped to about the same as the rate due to suicide, and the rank of HIV fluctuated between 4th and 5th place. From 1998 through 2007, HIV caused about 2,000 deaths per year, or about 5% of all deaths in this age group. From 2008 through 2009, HIV caused about 1,000 deaths, or about 3% of all deaths in this group. And then in 2014, HIV fell to 12th place and caused about 600 deaths, or about 1% of all deaths in this group. So in general, the death rate in women was lower than in men in the same age group, but the pattern was the same. We saw that spike in the 90s, followed by a decline. And that's all due to education, better understanding of the disease, what can be done to reduce risk, and, of course, treatments. Now let's look at HIV disease progression. We're going to be looking at HIV-1 here. The process begins when a person becomes exposed to HIV, which can occur through sexual contact with an infected partner, intravenous injection with contaminated needles used to deliver addictive drugs, or receipt of contaminated blood or blood products, for example, clotting factor 8 and 9 in the case of hemophiliacs. Once an individual becomes infected, HIV seeks out and overtakes CD4-bearing T lymphocytes to produce a struggle between viral production, which is tracked as the viral load, that is, the virus titer in circulating blood, and immune defenses that struggle to control viral proliferation in the beginning weeks. With more than 1 billion new HIV copies produced each day by an acutely infected person, and with new mutational variants arising at a rate of 1 every second virus copy, immune control is no mean feat. Nonetheless, in most infected people, the viral load settles to a chronic plateau level, which varies among individuals from 1 times 10 to the 3 to 1 times 10 to the 5th virions per ml, known as the viral set point. Over time, the virus gradually destroys the CD4 lymphocytes, and the blood count drops to below 200 CD4 plus cells per cubic millimeter. The time in which CD4 cell depletion occurs can vary from within a year of infection to more than 20 years later, with the mean time at approximately 10 years post-infection. Of course, now we're talking about people who have not received any antiretroviral drugs here. Once the CD4 cell count drops, the patient succumbs to a variety of normally innocuous infections like pneumocystis pneumonia, cytomegalovirus, herpes, TB, and so on, and to rare cancers such as Kaposi sarcoma and B-cell lymphomas. If left untreated, these infections and cancers almost invariably lead to deaths. 2 types of T cells are critically important in HIV infection. Most discussion of these immune cells refers to the subset known as CD4 positive cells, which is a cell type counted during most patient visits to gauge when to start antiretroviral therapy and to monitor the success of such a treatment over time. The other subset, known as CD8 positive cells or killer T cells, are also crucial because of their ability to control most viral infections. But even in the earliest stages of HIV infection, the performance of CD8 positive T cells, including their ability to fend off HIV and other viral infections, is suboptimal. In the late stages of infection, CD8 positive numbers decline. However, the reasons for these declines in the number of cells and their performance are not well understood. Researchers have previously noted that chronic immune activation is routinely seen in HIV infection, in which T cells, especially the CD8 positive T cells, are inappropriately on or active in terms of the immune hormones they secrete. Clinically, chronic immune activation contributes to premature aging effects such as heart disease, osteoporosis, and diabetes, all of which complicate the treatment of HIV. In mice that have been genetically engineered to be susceptible to HIV, previous studies have demonstrated a chain of events in which HIV infection of the thymus, which is the birthplace of all T cells, results in the production of immune hormone interferon alpha, leading to an increase in MHC1, which is a marker of infected cells, and naive CD8 low cells, Instead of responding actively to the infection as CD8 plus cells typically do, these cells respond poorly to the presence of HIV. But you can see it's a long disease progress. Again, this is what we see when a person does not receive any treatment. So you have your acute phase, and then a prolonged chronic phase with the viral set point, and then eventually the virus production breaks out of that set point, and you get a spike again in viral load, and you see opportunistic diseases and ultimately death of the patient. The symptoms of AIDS are primarily the result of conditions that do not normally develop in individuals with healthy immune systems. Most of these conditions are infections caused by bacteria, viruses, fungi, and parasites that are normally controlled by the elements of the immune system that HIV damages. Opportunistic infections are common in people with AIDS. HIV affects nearly every organ system. People with AIDS also have an increased risk of developing various cancers, such as Kaposi sarcoma, cervical cancers, and cancers of the immune system known as lymphomas. Additionally, people with AIDS often have systemic symptoms of infection like fevers, sweats, particularly night sweats, swollen glands, chills, weakness, and weight loss. The specific opportunistic infections that AIDS patients develop depend in part on the prevalence of these infections in the geographic area in which the patient lives. You can see in this illustration an X-ray of someone who has pneumocystis pneumonia. There's an increased white opacity in the lower lungs on both sides, which is characteristic of this pneumonia. Now, this pneumonia is relatively rare in healthy, immunocompetent people, but common among HIV-infected individuals. Before the advent of effective diagnoses of HIV, treatment and routine prophylaxis in Western countries, it was a common, immediate cause of death. In developing countries, it's still one of the first indications of AIDS in untested individuals, although it does not generally occur unless the CD4 count is less than 200 cells per microliter of blood. Kaposi sarcoma is the most common tumor in HIV-infected patients, and you can see that in the top left picture. The appearance of this tumor in young homosexual men in 1981 was one of the first signals of the AIDS epidemic. It's caused by a gamma herpes virus called Kaposi sarcoma-associated herpes virus, and it often appears as purplish nodules, as you see on the skin, but it can affect other organs, especially the mouth, gastrointestinal tract, and lungs. And actually, it was the appearance of the pneumocystis pneumonia and Kaposi sarcoma in otherwise healthy young adult males that led to the tip-off that there was some new disease happening in the United States. This started to occur in the early 1980s, and eventually it came to the recognition of AIDS as a disease, and then ultimately the identification of HIV as the causative agent of AIDS. HIV, of course, can be transmitted in three main ways: sexual transmission, transmission through blood, and mother-to-child transmission. In the U.S., HIV is spread mainly through unprotected sex with an infected partner or through sharing needles. It's not passed through water, saliva, sweat, or tears, insects, sharing toilets, and so on. Ending the HIV epidemic, a plan for America, was announced by President Trump in his State of the Union address on February 5, 2019. It's a bold approach to eliminate new HIV infections in our nation, and it's built upon the following key strategies. First, diagnosing all individuals with HIV as early as possible after infection. Next, you want to treat HIV rapidly and effectively after diagnosis to achieve sustained viral suppression. Then you want to protect individuals at risk for HIV using proven prevention approaches. And you want to respond rapidly to detect and respond to any new outbreaks. The new initiative seeks to reduce the number of new HIV infections in the United States by 75% within 5 years, and then at least by 90% within 10 years, for an estimated 250,000 total HIV infections averted. Okay, so how can we go about reducing the risk of HIV infection? There's actually quite a few steps that can be taken, and I'm willing to bet that you haven't heard of all of these. So first, correct and consistent use of male and female condoms during vaginal or anal penetration can protect against the spread of sexually transmitted infections, including HIV. Evidence shows that male latex condoms have an 85% or greater protective effect against the sexual transmission of HIV and other sexually transmitted infections, or STIs. Medical male circumcision, when safely provided by a well-trained health professional, reduces the risk of heterosexually acquired HIV infection in men by approximately 60%. This is a key intervention in generalized epidemic settings with high HIV prevalence and low male circumcision rates. We'll talk more about this on the next slide. A recent trial has confirmed that if an HIV-positive person adheres to an effective antiretroviral therapy regimen, the risk of transmitting the virus to their uninfected sexual partner, in the term we use for this is serodiscordant couples, can be reduced by 96%. For couples in which one partner is HIV positive and the other is HIV negative, it's recommended that that partner, the HIV positive partner, continually take their antiretroviral therapy. Trials also amongst serodiscordant couples have demonstrated that antiviral drugs taken by the HIV negative partner can be effective in preventing that individual from acquiring HIV infection from their HIV positive partner. This is known as pre-exposure prophylaxis, or PrEP, and we'll talk more about that too in another slide. Post-exposure prophylaxis, or PEP, is the use of ARV drugs within 72 hours of exposure to HIV in order to prevent infection. PEP is often recommended for healthcare workers following needle stick injuries in the workplace. PEP includes counseling, first aid care, HIV testing, and, depending on the risk level, administration of a 28-day course of antiretroviral drugs with follow-up care. The transmission of HIV from an HIV-positive mother to her child during pregnancy, labor, delivery, or breastfeeding is called vertical or mother-to-child transmission. In the absence of any interventions, HIV transmission rates from an infected mother to her child range anywhere from 15 to 45%. This form of transmission can be nearly fully prevented if both the mother and the child are provided with antiretroviral drugs throughout the stages when infection could occur. So we're going to talk about all of these steps in more detail. So first, let's look at voluntary medical male circumcision. Heterosexual transmission of HIV is still the biggest contributor to the HIV epidemic in sub-Saharan Africa. Remember, that's not the case in the U.S. and developing countries. So in the sub-Saharan Africa, over 70% of the estimated global 35 million HIV-infected people live. Male circumcision reduces HIV heterosexual transmission risk from infected women to men. It also reduces the risk of human papillomavirus, the incidence of herpes simplex virus 2 in men, and genital ulcers in the female partners of circumcised HIV-negative men. In 2007, male circumcision was recommended in 14 sub-Saharan African countries with high HIV prevalence but low levels of male circumcision. Male circumcision provides only partial protection and therefore should be only one element in a comprehensive HIV prevention package, which includes the provision of HIV testing and counseling services, treatment for sexually transmitted infections, the promotion of safer sex practices, the provision of male and female condoms, and promotion of their correct and consistent use. However, this part of the message is often lost, and it's really unfortunate because remember, condoms offer very high protection against HIV, much higher than the male circumcision. So why do a surgical intervention? And some of it is just based on poor messaging. Many individuals have been pressured either through advertisements and so on to get the circumcision, but then they leave thinking that this is going to protect them at a much higher rate than it actually is. Also, health experts are becoming increasingly concerned about the risk of the campaign for women. While it's true that male circumcision will reduce the HIV transmission from women to men, it does not work the same in the other direction. Circumcision offers, that is, male circumcision, offers no protection to women. An investigation in Uganda showed exactly how fatal this development is. For women with circumcised husbands, the HIV rate in the 6 months after the circumcision had drastically increased by 61%. And one of the doctors who initially pushed for the circumcision solution has now said that he's convinced that some women will become HIV positive because of the circumcision of their partners, because they fall into a false sense of security. Pre-exposure prophylaxis, or PrEP, is when people at very high risk for HIV take HIV medicines daily to lower their chances of getting infected. PrEP can stop HIV from taking hold and spreading throughout your body. It's highly effective for preventing HIV if used as prescribed, but it's much less effective when not taken consistently. Daily PrEP reduces the risk of getting HIV from sex by more than 90%. Among people who inject drugs, it reduces the risk by more than 70%. Your risk of getting HIV from sex can be even lower if you combine PrEP with condoms and other prevention methods. Post-exposure prophylaxis, or PEP, is a way to prevent HIV infection after a potential HIV exposure. It involves taking HIV antiretroviral medications, or ART, to reduce the risk of HIV transmission. PEP is taken daily for 28 days, or 4 weeks. If taken as prescribed, it can be effective in reducing the risk of HIV infection. Now let's look at how they can approach reducing HIV transmission in the drug-using population. So we can talk about harm reduction. The earliest forms of harm reduction promoted abstinence from drug use and put reducing its occurrence at the center of substance use policy and interventions. The concept of harm reduction was reinvented in the early 1980s at the beginning of the HIV epidemic, when healthcare workers started to provide clean syringes to people who inject drugs, rather than solely trying to achieve abstinence. Since then, there's been a slow but steady progress in implementing harm reduction programs as a component of the response to the HIV epidemic, with a wide range of initiatives tried to date in a variety of settings. Despite overwhelming evidence of the effectiveness of harm reduction for preventing the spread of HIV and reducing other harms associated with drug use, global harm reduction service coverage remains insufficient. Of 158 countries that report drug use, only 91% of them explicitly reference harm reduction in their national policies, so 58%. Moreover, of the countries where harm reduction services are available, few have achieved sufficient coverage. Australia, Switzerland, and the UK have reduced the number of new HIV infections among people who inject drugs to practically zero through harm reduction initiatives such as syringe exchanges and so on. Despite the proven benefits, harm reduction services are not available in many countries, and access is insufficient in most. Stigma and discrimination, the war on drugs, and lack of sustainable funding are all preventing rollout of effective harm reduction programs. HAART stands for Highly Active Antiretroviral Therapy. The first HAART treatments in 1996 included a protease inhibitor along with 2 nucleoside analog drugs to fight HIV. Now HAART means any potent combination of 3 or more anti-HIV drugs. HAART has become an extraordinary life-saving tool. Just a few years after HAART became widely available, studies reported 60 to 80% reductions in new AIDS illnesses, hospitalizations, and deaths. Because of HAART, many people with HIV/AIDS are living longer, more productive, and more normal lives. Successful HAART can change HIV disease from an illness that was almost always a death sentence into a chronic but usually manageable condition. Benefits of HAART include driving HIV levels, or the viral load, below detection in blood, semen, and vaginal secretions, and increasing the number of CD4 cells. Moreover, HAART contributes to fewer opportunistic infections and HIV-associated cancers. HAART has also contributed to overall quality of life. For example, some people who are on disability are returning to work and changing their plans for the future. More HIV-positive women are considering pregnancy because the rates of mother-to-child transmission have come down to only 1 or 2% for women on successful HAART regimens with undetectable viral loads. Although there are clear benefits of HAART, it also has its shortcomings and risks. HAART does not work for everyone. even for those who are successful and have undetectable viral loads. This is not a cure. The drugs only control HIV. They cannot eliminate the virus from the body. This means that HIV can still be transmitted through unsafe practices. In addition, people must stick to it, really adhere to a strict dosing schedule, or the drugs will stop working. Also, there are significant side effects associated with these drugs that can be difficult to live with and sometimes can be quite serious over the long term. There are several different antiretroviral drug categories. The nucleoside reverse inhibitors, or the NRTIs, also known as NUCs, nucleoside analogs, or backbone. This is the oldest class of antiretroviral medications. The NRTIs block HIV's ability to copy the cell's DNA, which the virus needs to make copies of itself. The non-nucleoside reverse transcriptase inhibitors, or the NNRTIs, block the same protein as the NRTIs, but are chemically different. Resistance to this class of medications develop quickly if not used in combination with an NRTI. The protease inhibitors, or the PIs, block protease, the enzyme that the HIV virus needs to make copies of itself. As a group, PIs are very potent and relatively well tolerated in the patient. And then we have the fusion inhibitors, or the FIs. This is the newest class of available ARV medications. The fusion inhibitors block HIV from entering the body's healthy cells. This medication must be administered by injection. But again, this shows you that understanding the molecular replication of the virus is critical in coming up with ways to treat the virus. We talked about this in the previous lecture a bit, and here you can see in the slide again how different steps in the virus replication has been targeted by these drugs very effectively. And you use several of these drugs in combination to avoid the development of resistance. ARV drugs keep HIV under control, but they don't stay in your body for a long time, so you have to keep topping them up. If you stop taking the HIV drugs, then the viral load will go up. This means HIV can damage the immune system, and then the person is more likely to pass HIV on. If a person regularly misses doses of their HIV treatment, there's a risk that the HIV in their body will become resistant to the medication, and the drugs will no longer work even when they do take them. So it's important that a patient takes their treatment correctly, the right dose at the right time, with or without food. There are many ways that a patient can get help to remember when to take their treatment every day, but it's absolutely critical that the patient adhere to their treatment plan, because as you can see in this slide, just because HAART was effective early on and they became undetectable, if you stop, it's going to rebound. So I used the term undetectable, and I've used it before. What exactly do I mean by that? An undetectable viral load is where the antiretroviral treatment, or ART, has reduced the level of HIV to such small quantities that it can no longer be detected by standard blood tests. People living with HIV who have an undetectable viral load cannot pass HIV on through sex. Being undetectable, however, does not mean that the HIV is cured. There is still HIV in the patient's body, although it's been reduced to very small amounts. This means, again, that if the patient stops taking treatment, the viral load will increase, and that will affect the patient's health and make HIV transmittable again. Now, one problem with this is that you can't tell if a patient has an undetectable viral load simply by how healthy they look and feel. The only way to know what a patient's viral load is by regular viral load monitoring. Viral load monitoring involves a simple blood test to measure how many particles of HIV there are in a small sample of blood. So, stated as how many HIV copies per milliliter of blood. From this, the patient and their healthcare worker can understand how well their ART is working. A low viral load means that the ART is working well and controlling the HIV. If the patient has an undetectable viral load, it means that the amount of HIV in the body is so low that they can't pass it on to other people through sex. The point at which a viral load is classified as being undetectable may vary across different countries depending on the tests available. But so long as the patient's viral load is under 200 copies per milliliter, they're considered to be virally suppressed and unable to pass HIV on. I mentioned earlier that a sizable proportion of people in the United States do not know that they have HIV, even though they are infected. So not knowing your HIV status can have a substantial impact on your survival, and this slide illustrates the most important reason for expanded HIV screening, because we have effective therapy. So looking at the slide, you can see the proportion of patients on HART in yellow and the rates of death in pink. And you can see there's unequivocal evidence for the benefit of the HART therapy in extending life. But of course, before you can start that therapy, you have to know what your status is. So there's some key facts. Education has led to leveling off of the rate of the increase in AIDS. It would be nice if the rate would continue to decline rather than stay at the plateau where we seem to be, but still, it's much better than it was. HART has greatly slowed the death rate. So that means that fewer people are dying per year from the infection, so that the number of HIV-infected people in the population is actually rising, even though the rate of infection has leveled off. So let's look at that in this next slide. So you can see here in yellow you have the number of cases. It peaked in the 90s and has declined, and now we see a plateau. And in blue we see deaths. It kind of shows a similar pattern to what we saw with cases, although fortunately it's much lower. But look at the orange line. That's prevalence, and it's steadily climbing up. And that's because of the treatment. With HART, we're seeing a decline in the number of deaths. People are living longer, which means that the percent of people who are HIV infected living with AIDS in the country is continuing to go up, even though we're seeing good news in terms of treatments and at least a leveling off of new cases. Advancing HIV prevention is a new initiative with a goal of reducing HIV transmission. It emphasizes the use of proven public health approaches to reduce the incidence and spread of the disease. And this initiative consists of 4 priority strategies. Make voluntary testing a routine part of medical care. Implement new models of diagnosing HIV infection outside of medical settings. Prevent new infections by working with persons diagnosed with HIV. And further decrease perinatal HIV transmission. So let's look at some of these things. First of all, awareness of HIV status amongst persons with HIV is important. You can see here the numbers. As I mentioned before, there's a sizable chunk of people who are unaware of their HIV infection status. And obviously this is important from the patient's point of view, because if you don't know you have HIV, if that diagnosis hasn't been made, you're not going to get treatment. And we've seen how treatment can increase life and improve the person's quality of life. But it has another effect as well. Let's look at this slide. So here you can see in the one column, it's people living with HIV/AIDS, and in the second column, new sexual infections each year. And the yellow indicates the number of people, if you look at the yellow in the new sexual infections, they were infected from the 75% of people who were aware of their infections versus the red, where you had 54% of new infections came from the 25% of people who were unaware of their infection. So it's estimated that sexual transmission accounts for about 32,000 of the 40,000 new infections that occur in the U.S. each year. Conservative estimates based on the changes in behavior observed once people find out that they are infected with HIV indicate that the 25% of people who are unaware that they are infected account for at least 54% and potentially as much as 70% of the new sexually transmitted infections each year. The transmission rate amongst those who didn't know they are infected is 3.5% times higher than the number of people who know about their HIV infection. So the importance of getting people tested and into care includes both treatment and prevention interventions. So, what this shows us is that for the most part, people do the right thing. If they know that they're infected, they're going to take treatments that can put them into the undetectable range, and they will be more careful about using other kinds of methods to prevent transmitting HIV to their partners. So people will do the right thing, but they have to know what their infection status is. Okay, so reasons for testing late versus early testers. What we see here are in red, the bars are people who were tested late and people who were tested early. That is, tested before or after their AIDS diagnosis. Remember, an AIDS diagnosis has to do with developing various kinds of symptoms of AIDS as opposed to just being infected with HIV. So people had various reasons for getting tested. They had symptoms, illness that made them think they might have HIV. They had a partner or someone at risk. They just wanted to know, a routine checkup, and so on, or required. For instance, people going into the military have to be tested. And it shows here most of those who were tested late were tested because they were ill. They had already developed symptoms. And this chart shows the reasons, again, why people were tested. And there's an intention through the CDC to make testing a routine part of medical care. So here, if we look here, this is to include HIV testing as part of routine medical care. In other words, we get tested for cholesterol levels, and our blood pressure is tested, and all kinds of things. Why not test for HIV as a routine part of this care? And then you can catch people early and get them treated. Because there tends to be a bit of a hesitancy for people to get tested. In some cases, it's because, they're just afraid of what they might find out, and so on. So if it was just a routine part of a medical checkup, people could get detected early and get treated early, and then lead to reduced transmission to other individuals. Now let's talk about the different types of HIV tests. There's actually quite a selection. There are both indirect and direct methods of HIV detection. Indirect methods do not detect the virus, but rather the proteins or antibodies that are produced by the immune system in response to the virus. Direct testing methods detect either antigens or the RNA. There are several testing options, and they all vary in their speed, accuracy, and ease of use. Rapid point-of-care tests can deliver preliminary results in around 20 minutes. They may require a blood drop from your finger, an oral swab from your gums, or a sample of urine. Of these, the preferred method is the blood-based combination HIV antigen antibody test. Standard point-of-care tests are lab-based tests that detect HIV antibodies only. This is the ELISA test. The test requires a blood draw, and the results are usually retained within 5 to 10 working days. The test is less commonly used today and has been largely replaced by the combination antigen antibody test. Rapid at-home tests are saliva-based antibody tests that can be purchased online or at many retail drugstores. While less accurate than a point-of-care test, the test offers privacy and can deliver results in around 20 minutes. There are also some home collection tests that require a drop of blood placed on a test card, which you can then send to a lab by express mail, and you can receive the results either by phone or online as early as 1 business day after your sample is delivered. And then we have the nucleic acid or NAT tests. These are blood-based tests that detect HIV RNA. While expensive, the NAT can detect HIV earlier than other forms of testing and may be appropriate if you've had a recent high-risk exposure or are experiencing acute symptoms of early infection. The NAT is also used to screen donated blood or test newborns suspected of having HIV. Results are usually returned within a couple of days. Any positive result, called the preliminary positive, would require a second confirmatory test to ensure the diagnosis is correct. The only exception to that would be the NAT, which does not require confirmation. Timing is an important part of HIV testing. If you've been infected with HIV, there will be a period of time called the window period when the test cannot deliver an accurate result. Because HIV tests generally detect antibodies and/or antigens, you need to wait until your body has produced enough of these to elicit a positive result. If you test too early, you will get a false negative reading. Even with the gnat, you need to wait until the virus has replicated to detectable levels, although it takes a shorter period of time to get a positive result from a gnat as compared to the other kinds of tests. Prenatal HIV screening, coupled with effective antiretroviral prophylaxis and appropriate obstetric management, has resulted in one of the major success stories in HIV prevention. The chance that HIV infection will be transmitted from an HIV-infected pregnant woman to her child can be reduced to 1% or less, so one or fewer out of every 100 pregnancies. This is possible because better medicines are available to treat HIV. But first, of course, the pregnant woman and her doctor must know if she is infected with HIV. Many women across the United States do not get tested for HIV during pregnancy. HIV-infected women who do not get tested often transmit HIV to their infants. 2005 CDC data show that among HIV-infected infants born in 33 states which report HIV-infected infants, 31% of the mothers of HIV-infected infants had not been tested for HIV until after delivery. Studies show that more women are tested when the HIV test is included in the standard group of tests that all pregnant women receive routinely, and when providers recommend HIV testing early in pregnancy to all of their pregnant patients. Since 1995, CDC has recommended all pregnant women be tested for HIV, and if found to be infected, offer treatment for themselves to improve their health and to prevent passing the virus to their infant. Since the time that therapy was shown to be effective for preventing mother-to-child transmission and universal screening was recommended, there's been a 95% reduction in the number of perinatally acquired AIDS cases in the United States. So again, just a huge success story here. And the key is just routinely test women, just like you test people for their cholesterol level. You can't look at somebody and know what their HIV status is, and sometimes people are embarrassed to admit that they think that there might be a risk. So it's better just to have an opt-out kind of philosophy where everybody is just routinely screened. So protecting the baby, here's the basic steps that can be taken to protect a child from acquiring HIV from their mother at or around birth. You want the mother to take her heart medications during pregnancy and childbirth. If the mother is at undetectable levels, her risk of transmitting the virus to the baby are very, very low. If the woman has a high level of HIV or an unknown level, then a C-section can reduce the risk of HIV transmission, because most often the child acquires HIV from exposure to the mother's blood at birth, as opposed to acquiring the infection through the placenta. And then lastly, HIV can be spread through breast milk. So if a woman knows that she has HIV, then she knows that she should feed her baby with formula rather than breastfeeding. So as I mentioned before, researchers have been working on an HIV vaccine since the 1980s, when we first recognized the HIV virus, but progress has been very slow. Finding at least a partially effective vaccine remains of critical importance for the HIV response. The biggest reduction in new infections would be achieved by a combination of PrEP, which is a pre-exposure prophylaxis that's used when people are at risk for HIV. They'll take a daily medication to prevent getting HIV. So PrEP can stop HIV from taking hold and spreading. Then we have antiretroviral treatments for people who are already infected with HIV, and then if we had a vaccine. The three of these things together could go a long way to really bringing the numbers of HIV infections down. So to still be useful, an HIV vaccine doesn't have to have the 90% or 99% efficacy that we saw with things like smallpox and polio. An HIV vaccine is a more realistic prospect today than a decade ago, and an optimistic forecast of HIV vaccine availability is that one might be available by 2030.